да? Діана, да? Починаємо. Good afternoon, students. Today we will speak about embryogenesis of cardiovascular system and congenital abnormalities of the heart and blood vessels. So we have to speak also about anatomic physiological features of the heart and blood vessels in children. The main functions of the organs of cardiovascular system in children consist in maintaining the homeostasis of the body, supplying the organs and the tissue with the oxygen, and eliminating carbon dioxide and the products of metabolism. You know that the heart is a hollow muscular organ collecting the blood from veins and pumping blood to the arterial system. The heart has 4 chambers, and left atrium and left ventricle comprise left heart or arterial heart, and right atrium and right ventricle comprise right or venous heart. And contraction of the walls of the heart refers to as systole and relaxation as diastole. And now we have to speak about embryogenesis of cardiovascular system. In the course of embryogenesis of cardiovascular systems, the vessels are formed the first. It happened on the 2nd week of embryonic development, and the cluster of the cells known as blood islands which appear, and they later give the origin to the blood vessels. The development of the heart begins since the 3rd week of embryonic development from the part of mesoderm. In the presumptive region of the neck, 2 primary endocardial tubes are formed. The growing endocardial tubes approach one another and finally fuse. The septum between them resolves, resulting in tubular primitive heart structure. The internal layer of the tube is referred to as endocardium, and external layer epimyocardium. External layer develops later into muscular layer or myocardium and external envelope or epicardium. The internal layer gives rise to endocardium. The broadened caudal end of the heart tube forms the venous sinus, receiving the primary veins. And the cranial part of the heart tube is named as cardiac bulb, from which later the arterial trunk originates. Middle part of the heart tube dilates, generating the ventricle and atria. The tube grows intensively within the 3rd week of embryonic development, bending into S shape, and the heart turns around the axis, approaching the frontal one. The part of the heart between the atrium and the ventricle narrows, initiating the formation of the atrioventricular orifice. In the middle of the 4th week, 2 primordial chambers of the heart are generated. Throughout the 4th, 5th week, the partitioning of the atrium begins with appearance of the interatrial septum with the oval foramen. And oval foramen contains the valve on its left side. Within the 5th week of embryonic development, the interventricular septum is formed, growing from the apex towards the atrium, and for sometimes the foramen between the ventricle exists. Later, the interventricular foramen overgrows with the connective tissue. Within the seventh week, the partitioning of ventricles become to the end, and at the same time, the common arterial trunk separates to aorta and a pulmonary trunk. The formation of the valves of the heart follows the formation of the septa, and valves grow as the duplicature of the endocardial layer. At the end of seventh, eighth week, the heart has a four-chamber structure, and since the eighth week, the heart descends from the germinal position in the presumptive neck region into the thoracic cavity. From the fourth week, the conducting system of the heart begins to generate with its major structure, namely sinoatrial node, atrioventricular node, and atrioventricular His bundle and Purkinje fibers. Meanwhile, in the embryonic heart, the additional bundles of the conducting system are found out. Left and right Kent's bundle between the atria and ventricles, James bundle connecting the atria with atrioventricular node, and Machaim's bundle connecting the atrioventricular node with the myocardium of the ventricles. All these additional bundles degenerate before the birth. Meanwhile, in 0.2% of adults, this embryonic conducting paths are partially preserved, and the preservation of the embryonic elements of heart conducting system may be the cause of paroxysmal tachycardia and arrhythmia in children. So the formation of the heart and major blood vessel is completed within the first 3 gestation months, coinciding in time with development of the placenta and placenta circulation. I would like to tell you that circulation system also has several stages of its development. And the first two stages of the development of the blood circulation system are rudimentary. And for us is very important the placenta blood circulation, which forms since the end of the second, beginning of the third month of gestation. And fetal blood circulation has several peculiar features. Fetal tissues are supplied with a mixture of arterial and venous blood, as there are several specific paths of blood circulation in fetus, such as ductus venosus, ductus arteriosus, and oval foramen, and pulmonary circulation does not function, and ventricles counteract synchronously. On this slide, you can see the scheme of the fetal blood circulation. So the arterial blood collecting from the villi of placenta enters the body of the fetus via the umbilical cord. Here it has a red color. And throughout the fetal stage of the development, maternal blood supplies the fetus with oxygen and nutrient and carries away carbon dioxide through the placental blood circulation. And umbilical vein runs to the hills of the liver and divides into two branches. One of them, Arantus duct, joins the inferior vena cava, and another branch that joins the portal vein carries the oxygen-saturated blood diluted partially by venous blood to the liver, and then the blood flows to inferior vena cava via the hepatic vein. The blood from inferior vena cava enters the right atrium, and the blood enters the right atrium, and the blood from the head and upper limbs also enters the right atrium via superior vena cava. And then the blood from the right atrium enters the aorta by two paths. Through the oval foramen from the right atrium to the left one, and then to the left ventricle and ascending aorta. A portion of blood, about 10% of all blood, runs from the right atrium to the right ventricle and then pulmonary trunk. Since the pulmonary circuit in fetus does not operate, and pulmonary blood vessels have a high resistance to flow, this portion of the blood is directed from the pulmonary trunk to the arterial arch via ductus arteriosus. So the liver, the head, and the upper part of the fetal body obtains the blood, which is more saturated with oxygen and nutrients, providing for more intensive development of these parts of the body as compared with the pelvic organs and lower limbs. I'd like to tell you that the first counteraction of the fetal heart takes place in the fourth week of the intrauterine development. First, the fetal heart rate is rather low, nearby 15-35 beats per minute. As soon as placental circulation is formed, the heart rate increases up to the 125-130 beats per minute, and such a rhythm is rather stable in normal gestation, which is a pathological condition. The deceleration or acceleration of the fetal heart rate is possible. And when the baby was born, and at the birth, the placenta circulation interrupts, and fetal vascular communication are closed, and pulmonary circulation is switched on in full, and vascular resistance in pulmonary circulation decreases 5-10 folds, and the systemic vascular pressure increases. So when the child was born, we can see also on this picture the scheme of the neonatal circulation. So the placenta circulation finished, the fetal and fetal communications closed, begin to close. You have to know that after the birth, the vascular resistance in pulmonary blood vessels decrease from the first month, decrease 5-fold by the by the second month 10-fold, and they increase left atrial pressure and decrease right atrial pressure causes the closure of the foramen ovale by the valve. So the flow of the blood from the right atrium to the left one terminates, and within 2 weeks after birth, the foramen ovale is joined with the valve, resulting in the anatomical closure of the foramen within 5th, 7th month after the birth. But sometimes the foramen ovale is present anatomically for a long period in 50% of the children up to the end of the first year of life, and in 15–30% of the persons, the foramen ovale is present throughout the life. And I would like to tell you that the open foramen ovale may be because of the congenital heart abnormalities. Within the first minutes after birth, Arantus duct is closed, but the complete obliteration or anatomical obliteration of ductus venosus occurs within 8 weeks of postnatal life. And with the first breath of the newborn child, the spasm of ductus arteriosus occurs. Meanwhile, ductus arteriosus operates throughout the first 8 hours of postnatal life, providing for two-side outflow of the blood from aorta to the pulmonary artery. And anatomical obliteration of the ductus arteriosus completes within 6–8 weeks of postnatal life. Sometimes ductus arteriosus, as well as other fetal blood communications, do not completely close, resulting in formation of the congenital heart defects. And what is congenital heart defects? This is a physiological status incorporating the abnormality of the positions, morphological structure of the heart and major blood vessels, resulting from the disordered intrauterine and postnatal development. And more than 2% of newborns have congenital heart defects. And without surgical operation, 50–75% of children with congenital heart defects die within the first postnatal year. On this picture, you can see the prevalence of congenital defects of the heart and the blood vessels in children according to Nelson textbook of pediatrics. And I would like to tell you that ventricular septal defect occurs more often than others. Etiology of congenital heart defects. We can artificially subdivide it into 5 groups. The first group, congenital heart defects originating due to influence different multi-factors causes. Then congenital heart defect with Mendelian inheritance. Then congenital heart defect can be as a component of monogenous or chromosomal syndrome, and the fifth, congenital heart defect resulting from teratogenic effects. And the first congenital heart defect with Mendelian inheritance. If there is a congenital heart defect in relatives of first degree, so this is parents or full brothers and sisters, the risk of formation of heart abnormality equals 50% for defects with autosomal dominant inheritance. If there is a congenital heart defect in relatives of the second or third degree, the risk of the formation of heart abnormalities equal 25 and nearby 13% accordingly. Then congenital heart defects originating due to multi-factor causes, nearby 40%. These congenital heart defects mostly originates from the mothers which has pathologies, endocrine pathologies. And the age of parents affects the realization of gene mutation and chromosomal aberration. When the age of the mother is more than 35, 40 years old, and father more than 40, 50 years old. And genetically determined syndrome associating with congenital heart defects. You can see on the picture chromosome diseases. This is trisomy for 21 chromosome, Down disease, Patau syndrome, Cheryshev-Turner syndrome, Edwards syndrome, and other. And congenital heart defects are also included in monogenic and polygenic diseases, and exogenous cases or causes of congenital heart defect, we can subdivide it into big three groups. The first, infectious, with inclusion viruses and other infectious agents. Then different chemical substances like drugs, alcohol, varnishes, paints, and the last physical factors are high atmospheric pressure, radiation, and solar radiation. A classification of the congenital heart defects. All congenital heart abnormalities are classified according to cyanosis and pulse oximetry for acyanotic and cyanotic. And further, these two groups are subdivided according to X-ray data for congenital heart defect with increased pulmonary circulation, congenital heart defect with decreased pulmonary circulation, and congenital heart defects with normal pulmonary circulation. And then acyanotic congenital heart defects subdivided also into two groups with a volume overload of pulmonary circulation. So these congenital heart defects have left to right shunts. So this is a patent ductus arteriosus, atrial septal defect, and ventricular septal defect. And with pressure overload, stenosis of pulmonary artery, coarctation of aorta, and stenosis aortic valves. And cyanotic congenital heart defect with decreased pulmonary circulation, tetralogy of Fallot, atresia of tricuspid valve, and others, and with increased pulmonary circulation, transposition of major blood vessels. And on this picture, you can see the example of the diagnosis. So you have to write congenital heart disease, then you have to name it and write cyanotic or acyanotic and shunt. If a patient has overload of pulmonary circulation, the pulmonary hypertension develops. And there are three stages of pulmonary hypertension. The first stage is hypovolemic phase, when the vascular capacity does not match the blood volume. And in this case, the pressure in pulmonary artery is normal or moderately elevated. The next phase is a mixed phase, when we can see the vascular spasm. So vascular spasm develops, and it names syndrome Kitaeva. And vascular spasm develops in a response to hypovolemia, and pulmonary pressure and vascular resistance increase, and left to right shunt decreases. And long-term spasm of blood vessels and hypovolemia cause irreversible sclerotic changes in pulmonary blood vessels, and the last stage develops. So now we have to speak about anatomical features of the heart. I'd like to tell you the heart of newborn is bigger than heart of adults, compared with body mass. And in newborns, the size of atria and major blood vessels exceeds that of ventricle, and size of the ventricles are equal, and the thickness of the wall is the same. And with the age, the left ventricle dominates by size over the right ventricle, and thickness of the wall of the left ventricle increases threefold with age, and thickness of the wall of right ventricle only a third. The growth of various chambers of heart is different. The growth of atria is more intensive up to the age of 2 years. Whole heart grows more intensive at the age from 2 to 10 years. And at the age above 10 years, the growth of the ventricle predominant, and up to the age of 6 years, the heart is round in shape, and later on it becomes oval. Up to the age of 2-3 years, position of the heart on diaphragm is horizontal, and after that, when the child grows, the heart occupies oblique position, turning around the long axis, the left ventricle forward, and at this time the apex beat is generated by left ventricle. And later the heart occupies the vertical position in the thoracic cavity. You have to know the position of the apex beat of the heart, and on this slide you can see the normal position of the heart in ages. So in newborn, the apex beat of the heart we can palpate in fourth intercostal space, 1-2 centimeters outside of the left mid-clavicular line. And then when the child grows, at the age of 3-7 years, we can palpate the apex beat in the fifth intercostal space, 1 centimeter outside the left mid-clavicular line, and at the age 7-12 years, like in adults, in the fifth intercostal space, 0.5 centimeters midline of the left, medial of the left mid-clavicular line. And now several words about peculiarity of the cardiac cardiac muscle. In newborn, the myocardium has the features characteristic for embryonic myocardium, representing undifferentiated symplast with rich vascularization, with very thin fibers, muscular fibers, with a large amount of nuclei, and with underdeveloped of the elastic fibers. And I'd like to tell you that myocardium of atrium consists of 2 layers of muscular fibers, and myocardium of ventricles consists of 3 layers of muscular fibers. A conduction system in a newborn is imperfect, and with age, connective tissue develops intensively. Muscular fibers begin thicker, elastic fibers appear, conduction system develops, and the development of myocardium terminates until the pubertal period. On this picture, you can see the heart with 4 chambers, 2 ventricle, 2 arteries, and major blood vessels. So we have spoke about anatomical peculiarities of the heart. But heart has also functional peculiarities, and there are 2 functions of the heart. Pumping provides for blood blood flow into aorta and pulmonary artery, and the next contractile function characterized by heart rate. And pumping function has 2 parameters. the stroke volume and cardiac output. And two parameters increase in within the age. And but stroke volume increases more intensively. And on this picture you can compare increasing of stroke volume and cardiac output in children of different age. And contractile function of the heart, you can see the heart rate. Also, the heart rate depends on the age. The next about what we have to speak is a cardiac cycle. The cardiac cycle, this is a whole complex of electrophysiological, biochemical and biophysical processes in heart from the beginning of one heartbeat to the beginning of the next. And beginning of the heart cycle is marked by appearance of P wave in electrocardiography. And I would like to tell you that the duration of heart cycle in newborns is less than in adults, and in adults it increased due to duration of the diastole of ventricles. And several words about peculiarities of the blood vessels in children. The arteries in newborns are wider than in adults. The diameter of the arteries in newborns and the young children are wider than veins. And with the age, the veins grow faster than arteries. As a result, at the age of 16, the diameter of veins is twice as wide as than of arteries, and the blood vessels in newborn have thin wall with underdeveloped muscular and elastic fibers. And the development of the blood vessel is finished at the age of 12, 13 years. Blood vessels also has functional peculiarities, and the indices of functional blood circulation are the circulation rate, the pulse valve velocity, and arterial blood pressure. Blood flow velocity in children exceeds that in adults due to more frequent heart rate, a large relative volume of the circulating blood, relative shorter blood vessels, and more intensive metabolism. Pulse valve wave velocity in children is less than in adults due to less elastic fibers and muscular fibers in arterial walls in children. And several words about arterial blood pressure in children. They also, this parameter is also less than in adults. And the reason of the low arterial pressure in children, first of all, less development, pumping, and contractile function of the heart, relatively wide diameter of the arteries, and elastic fibers of the walls of arteries are underdeveloped. And arterial pressure comprise systolic arterial pressure and diastolic arterial pressure. And systolic arterial pressure at birth is 76 millimeters hydrarchium, with monthly increment to millimeters hydrargium. And for calculation, the normal arterial pressure, systolic arterial pressure, for the child below 1 year, we can use following formula: 76 plus 2 multiplied by n, where n age in months. And so at the age of 1 year, systolic arterial pressure is 90 millimeters hydrargium, with its further annual increment of